Amit Mathur is a surgeon, but a fantastic surgeon and sort of a thoughtful person who's contributed considerably to policy in kidney transplantation. So, welcome, Amit. So, Dr. Mathur is a professor of surgery at the Mayo Clinic in Arizona, but he's a multi-organ transplant surgeon involved in liver, kidney, and pancreas transplantation. He has several leadership roles, including surgical director of liver transplantation, director of transplant quality, and the associate medical director in contracting and payer relations. He has a long-standing interest on the intersection of access, outcomes, and financial issues related to transplantation. He serves as the co-director of the National Living Donor Assistance Center that helps to address financial barriers in living organ donation. Dr. Mathur earned his undergraduate and medical degrees from the University of Florida. He completed a general transplant and hepatobiliary surgery training at the University of Michigan, and has since completed a 2-year health services research fellowship and a master's in health and healthcare research from the University of Michigan School of Public Health, and finally was a visiting scholar at the Scientific Registry for Transplant Recipients. Welcome, Amit, and we're looking forward to a fantastic talk.
Thank you, Sumit, and thank you everyone from the ASN for the invitation to speak on an area where I feel is a very important one in terms of some of the economic issues that we face in the transplant side of taking care of patients with kidney disease. And so I'll be talking about the financial impact of living kidney donation on donors, recipients, and the healthcare system. And this may be a little bit of a different view of some of the how we traditionally think of financial issues in kidney disease. But I think a good corollary or addition to today's program overall. As Sumit mentioned, I'm the co-director of the National Living Donor Assistance Center, which is the sort of operational arm for the HRSA-funded Living Organ Donor Reimbursement Program. And so my views today do not represent the NALDAC, the grant program of the LODRP, or HRSA. But I have a longstanding interest in how financial issues affect living donors, living donor decision-making, and the system at large. So as we've talked a lot about today, some of the best therapy that we know of for patients with kidney disease is, of course, transplantation, and certainly better with regard to the overall mortality when you look at the population at large. But we know that even amongst patients who have access to transplantation, the best long-term outcome is with living donor transplantation. And you can see here the mean post-transplant graft survivals at 10 years approaches around 80% with excellent physical, emotional, and social quality of life reported by recipients themselves. And so one of the important questions is, transplantation is in general, a clinically superior long-term option compared to chronic dialysis for select patients who go through an evaluation process at a transplant center. But the current landscape of kidney transplantation would suggest that we aren't actually meeting the mark of providing best possible care to patients. And you can see that from some of the data that we've discussed today. And as Dr. Mannon alluded to in her presentation as well, is that we've really had a lot of growth in kidney transplantation overall over the last 10 to 12 years in the United States. But most of that growth in fact, all of that growth has really been in deceased donor transplantation. Living donor transplantation has largely stagnated. In fact, relative decline since before 2019. And our best year in living organ donation and successful living donor transplant was actually back in 2019, right before the pandemic, which you can see highlighted here in green, where we completed just over almost 7,400 living donor transplants. But our next two best years were 2004 and last year. And so we are still in the process of recovering from the pandemic, where we had one of our lowest years to date, despite knowing the benefits of living donor transplant. Of course, we had a worldwide pandemic going on at that time, and elective surgery was frozen. So what we are, left with is sort of trying to understand what is stopping us from doing more living donor transplants when we know that it's the best available therapy for patients with who are facing a life on dialysis. Well, when we think about the barriers to expanding living kidney donation, I think there is a myriad number of reasons why we haven't grown in comparison to living donation or rich living donation cultures in other parts of the world. And one of the problems is, of course, getting people to the door to be evaluated. And then also there's issues that come up after people get into the door when they're considering becoming a donor and going through the evaluation process. Now, if you think about what transplant programs think about, they are considering medical, surgical, and psychosocial fitness for donation. But it's important from, especially this being a financially oriented program, to understand some of the donor-centered concerns. And at each step in the process, financial concerns are a very pertinent issue to the potential donor. It prevents them from walking into the door to start with, but then at each step, as they learn more about being a donor, what donor surgery is going to look like, recovery time, what the long-term implications are for costs are really important and do play a role in the psychology of living donor decision making. And there's ample evidence to support the notion that this does affect decision making, and we'll kind of discuss some of the data on that. When it comes to living donation and this intersection of sort of how financial issues play into things, we have both indirect and direct evidence. And so one of the best studies on this topic was a population-based study in Canada published by John Gill's group in 2015. And they demonstrated that over a 10-year period, that living donation rates per million population were income sensitive. You can see very little overlap between these donation rates per million population by income. And so this was further substantiated by Jim Rodrigue and his group in Boston in the KDOC study that showed that the highest rates of living donation in that donor outcomes study were really completed by those with the highest household incomes. We see further indirect evidence of sort of the impact of finances on living donor decision making based on sort of broader economic data. So if you look at the sort of most recent large recession that we've seen worldwide, in particular in the United States, you can see that living donation rates really declined during that time. In particular, those that were from related and spousal donors. The only areas that we've really seen growth since that recession has been in unrelated donors, as well as and now more recently in paired donation. And so the stress on family resources from these economic upheavals do affect whether or not people feel they can go forward with diverting themselves away from being at work to go through with donation, recovery, and so on. And that does affect, whether or not they would even be willing to come forward. So one of the important questions we've always been interested in my group and in the operation of the NALDAC was really trying to understand how much it costs to be a living donor. If I'm interested in being a living donor to anyone, how much is it going to cost me? And so one of the things that's important to think about is what does cost mean? Well, cost can be direct costs such as transportation, lodging, food, travel costs, maybe some uncovered medical expenses. Usually the medical expenses, of course, are covered by recipient medical insurance, but there can be incidental medical expenses, dressing supplies, things like that that won't get covered by insurance. There's also indirect costs, so lost wages that I would have to take to be off of work, to have an evaluation or undergo surgery or recover from surgery. Use of PTO is an indirect cost. Going through living donor surgery is not a vacation. And so loss of PTO is an indirect cost, as well as issues related to dependent care, long-term insurability, as well as job retention. Some people do have jobs at risk if they don't show up, on a regular basis. And they may work in the gig economy where their jobs are insecure by nature of the work. And so those indirect costs are very important components of cost. So when we've studied this as a society, there's two really great studies that were published in AJT in the 2010s by Jim Rodriguez and as well as Clarenbach as well in the Canadian context. And what these two studies demonstrated was that there is considerable amounts of out-of-pocket and lost wage costs from actual donors. And so if you look at this time period and when these studies were published and the amounts of money that were being reported of loss by the living donors, we're talking about $3,000 to $4,000 in 2010 dollars. And if you take the cumulative inflation rate based on the consumer price index from 2010 to now, it's approximately 45% cumulative inflation. So we're talking about $5,500 to $6,000 of costs in today dollars. And that's a considerable chunk of money considering the median household income in the United States is around $80,000. So out-of-pocket costs and lost wages can really represent and can be extrapolated to represent greater than 10% of annual income for a large portion of the US population. And not only does it cost money to be an actual donor, meaning these are people who actually had surgery, it actually costs money to not be a donor. So people who just go through the evaluation process, go to the transplant center, the back and forth of that, potentially being out of work, childcare, et cetera, there are substantial costs related to that. And when we last measured this about 10 years ago, it was around $1,000. And you can imagine what that extrapolates to in 2025 dollars. So it costs money to be a donor. It costs money to not be a donor and to just be considered. And so these financial issues do play a role. And there's been some large cohort studies that have substantiated that as well. The ReLive study looked at living kidney donors over 50 years. So this is one of the largest multi-center living donor studies that looked at kidney and lung donors actually back from 1963 all the way to 2005. And living donors reported in surveys that some of the most substantial issues that they had were non-medical financial costs, particularly if they were of lower educational level attainment. They also report insurance coverage issues. So this is a study that was published back in 2015, but there's a more recent public survey that was conducted at University of Colorado Hospital, just amongst people who are walking around the hospital on the day. And they were queried about donating a liver, but the questions really remain germane to the kidney discussion as well, which was what do donors really worry about? And these were the top 4 discouraging factors of 14 in terms of willingness to consider donation to a stranger. And so one of the most important issues was uncompensated medical expense or uncompensated expenses overall. And so expenses do play a role in actual donors, as well as people who might potentially be donors, i.e. those who are in the general public at this time. So these are real costs that people may encounter in the donor evaluation process, the recovery process. And so who can pay those costs? So that's an important question. Well, actually, there is a multitude of sources of funding to support those costs. So donors, of course, can self-subsidize. They can pay for it themselves, and most often that is the case. However, donor employers, insurance companies, or other payers can do this. Recipients are permitted to do this. That does not represent valuable consideration under the National Organ Transplant Act. There are state-based programs that can be used, charities. One of the most avidly used reimbursement programs are through the paired exchange programs, the National Kidney Registry and the Alliance for Kidney Paired Donation. charities can do this, and as well as the National Living Donor Assistance Center in its operation of the Living Organ Donor Reimbursement Program. And so the way these programs emerged was actually through a very specific legal framework. The National Organ Transplant Act, of course, prohibits the buying and selling of organs, but specifically in that piece of legislation, it did allow the reimbursement of travel, housing, and lost wages incurred by living donors. And a follow-up act called ODRIA that was passed in 2004 stated that the government could cover some of these expenses if another source was not covering it for them, such as an insurance company, state compensation program, or the recipient of the organ. And so that is actually what led these two pieces of legislation were what allowed for a federally funded program, which is now the Living Organ Donor Reimbursement Program, which we operate through the NALDAC program, which is a grant that we've operated since 2007. It is available at all U.S. transplant centers. And financial support can be provided on a means-tested basis. The program is directed towards low-income individuals, and it can cover up to $6,000 in travel and or lost wages and or dependent care. And based on the means testing threshold, that would cover approximately 50% of the U.S. households. Based on our last census inquiry on household income size. A couple of remarks about the paired exchange programs and their provision of addressing living donor financial disincentives. The NKR Donor Shield offers lost wage reimbursement and donor expense reimbursement for travel as a part of the Donor Shield program, which also offers other protections to living donors. And this is a program that is available at select transplant centers, but a growing number all the time. This is the distribution of those centers across the country, and they are the largest paired exchange algorithm program available in the country. The Alliance for Paired Kidney Donation also provides similar protections to the donors that participate in their paired exchange algorithm through the centers they partner with. That includes lost wage reimbursement and travel expense, as well as dependent care and other protections as well. Pet care has been one as well. So costs really are meaningful to donors and have become a part of this sort of national milieu of donor protections, which is a wonderful thing to see. There are state-based programs that do this. Iowa is the most cited one. That's a grant-based reimbursement program. The state of New York has passed a law that allows for state-based living donor reimbursement, and that program is in development at this time. Shifting gears to the impact of living donation on transplant recipient finances, I think is an interesting topic. Because it's not something we always necessarily think about. A lot of the studies on these topics are much older. It doesn't seem like people are as interested in financial issues for recipients anymore, because I think it's more of a sign of what are we supposed to do about it. But one thing that's important is that information with regard to understanding the financial impact of living kidney donation on recipients is skewed. And that's simply because the people who receive the population sort of demographics for those who receive living donor kidney transplants is skewed as well. You can see the racial and ethnic distribution of kidney transplant recipients by graft type. On the left side of the bars there is the deceased donor kidney transplant pool. For example, amongst Black patients represent 36.6% of the deceased donor kidney transplant recipient pool, but only 11% in the living donor side. White patients represent 33.8% of the kidney transplant recipients on the deceased donor side, but 61% on the living donor side. And there is a substantial breakdown when it comes, substantial difference rather, when we look at insurance breakdown. With deceased donor kidney transplant, it is predominantly government paid. 73% of deceased donor kidneys are covered by government or other sources of funding, and only 27% are commercially insured. Whereas in living donor transplant, it is the majority are commercially insured patients, 54%, compared to 45% in the government side. Now, some of the reasons for this skew also by race and ethnicity and insurance may also be related to historic trends in household incomes by race ethnicity. There is continues to be over time lower household incomes amongst those who are self-report as Black race or Hispanic ethnicity. And that that gap has not been fully bridged. And so for those who are potential kidney transplant recipients from those communities, they may also be have lower household incomes, and that may further the financial impacts may be further exacerbated simply by the incomes that are present in those populations. Now, living kidney donation does have a substantial impact on kidney recipients in several domains. So, for example, a living donor transplant is typically an earlier transplant. Most of the patients who receive a living donor transplant have less than 3 years of dialysis time based on current OPTN and SRTR data, as well as data from the USRDS. And so an earlier transplant does opt for patients who have, not yet been put on Medicare-based insurance. May also have there's a higher proportion of preemptive patients who receive a living donor transplant. There is a higher likelihood of earlier return to work. However, when people do have a transplant, there can be insurance coverage gap, which is an important financial consideration for recipients. There is also sometimes the responsibility or burden, and sometimes that's psychological, of supporting the donor's expenses by the recipient. Albeit in my experience, I don't see this that often amongst living kidney recipients. That doesn't necessarily mean it's not happening, particularly amongst family members or close friends. Medication costs, of course, in the post-transplant arena are a considerable issue. Insurance coverage for medications is a requirement at most U.S. transplant centers, but sometimes are associated with substantial out-of-pocket costs. And so I think it's important to understand that in each of these domains, I won't go into all of them on the recipient side, but living kidney donation does affect the finances of the recipient in a substantial way, some for the positive, like return to the work. But being a living donor kidney transplant recipient, you will live longer, you'll have a better quality of life, but it does come at a substantial financial cost. So there is substantial evidence for return to work after living donor transplant. So this is a little bit older study by the University of Minnesota group, but they reviewed 2,500 living donor kidney transplants at their center. And based on the time point when they did this analysis, which was over more than 20 years of living donors, 55% of those people or more were employed or going to school at the time of the analysis. Only 16% were reported to be on disability, and there was some missing data, of course, when it comes to return to work, which is often the case, since it's not a clinical outcome we necessarily track. But this is an important piece of information, that return to work allows for a higher economic outcome when somebody can access a living donor transplant. When it comes to returning to work, there is often insurance transitions, particularly for those who are on government insurance and then return to work and are able to receive employee-based insurance. There was a great study that was published a couple of years ago in Progress in Transplantation on this issue. And what it demonstrated was that patients who received a transplant, who returned to work and acquired non-Medicare insurance, those patients had a 10% lower risk of graft failure at 3 years. And that was borne out in, I would say, a very elaborate multivariate analysis with, adjusted for confounding and the interaction of several variables that were in their conceptual model. And so they were able to really demonstrate that it wasn't just changing insurance and returning to work, or keeping Medicare and not returning to work, or keeping Medicare and returning to work. They were able to really demonstrate that it's an insurance change and returning to work that's protective from the long run. And I think that is a testament to the health status that comes from being able to go back to work, and also having oftentimes better coverage in the commercial market. So a few remarks on the financial impact to the system from donor cost reimbursement. I think that you can think about sort of impacts on the system in a variety of ways. So one of the ways would be to think about, well, what happens if we do more living donor transplants as a society? What happens to the cost of total system care for kidney disease patients? What's the return on investment for creating or expanding living donor reimbursement programs? And then how does living donor transplant compare to deceased donor transplant in healthcare expenditures? And then also, how does the occurrence of a living donor transplant affect the financial margin of a transplant hospital? So we are all, I think, familiar with USRDS data on the per patient per year expenditure costs of dialysis versus transplant. And you can see that, these are a little bit older slide now, but the dialysis costs are approaching about $100,000 per year in 2025. And transplant maintenance costs, less the first year after transplant, really are still sticking around under $50,000. And so transitioning a patient from dialysis to transplant is a substantial cost savings for the system once you amortize the sort of the cost of the first year, meaning the cost of the surgery and the early hospital use. We sort of looked at this in the NALDAC with the NALDAC team, trying to figure out, well, the investment in a national living donor reimbursement scheme could have actually a massive return on investment for the CMS, end-stage renal disease program, which represents about between 7 and 10% of all Medicare expenditures, which is a substantial amount of dollars, as we talked about earlier in the conference today. And so we conducted this study. Now it's been about 10 years, and we're looking forward to updating this study with new categories of expenses that we now cover in the program. But our question was that what is the ROI for federal dollars spent on the reimbursement scheme that NALDAC coordinates when accounting for potential cost savings from dialysis? And so we developed a mathematical model for return on investment over time, which was essentially a ratio of total dialysis costs minus operational costs for the program, plus the cost of the transplant divided by the program costs. And that gives you sort of a return on investment of every dollar that's invested in a federal reimbursement scheme for living donors. So we looked at about 4 years of data from 2012 to 2015. We merged NALDAC data with SRTR and USRDS data for waitlist and cost data from USRDS. And what we found was, for one, I think this is a well-known fact in the dialysis community, that there is state-by-state variation in dialysis costs, and there was a 2.3-fold range of variation in dialysis cost per patient per year. And then there was also a 3.4-fold range of variation of median transplant cost per year. But the approximate difference between dialysis costs versus transplant costs was around $50,000 per patient per year. And this was based again on 2011 dollars. That amount is still true today. So when we calculated out the return on investment for a living donor financial reimbursement scheme, we see that for every dollar invested in that scheme, in the first year, there's $5 returned to the dialysis CMS ESRD program, and then that extends out to 19-fold return on investment at 3 years, and then a 28-fold return on investment at 5 years. So this is a substantial return on investment. This is like investing years ago in NVIDIA or Bitcoin or something like that. And so it would behoove us to expand any opportunity that we have to get more patients off of dialysis, especially considering the finances do make a difference to living donors. And so it seemed that the largest savings were experienced in those states that had the longest waiting times. And so that makes sense when you think about how much it costs to run a dialysis program in California, for example. So what that kind of gives us an idea is that there is significant savings by shifting the cost profile from a lower tier of annual costs or to a lower tier of annual costs from higher cost dialysis care. We don't know about a lot of ROI from non-federal sources for living donor reimbursement. But if you take a bird's eye view of things, living donor cost reimbursement rules from the NALDAC program, but also the other programs that are out there that reimburse living donors versus annual dialysis costs, the expense reimbursement really represents a small fraction of total annual spending, and so the savings are really massive. When you look at what living donor transplants cost for healthcare expenditures, this is actually reportable using Medicare data, but I haven't seen a recent study on that. This was a recent study actually done in Japan, which has really robust administrative data on healthcare costs. And while the dollars may not necessarily transmit, I think what is important to see is that year one costs for living donor transplant are lower than deceased donor costs. And then after the first year, there are significant savings with living donor transplant as years go out. And that costs end up being lower for living donor transplant than deceased donor transplant when you look at the total healthcare expenditures of transplant recipients. So living donor transplants in general provides greater system savings. This is related to a lower rate of complications, lower rates of graft loss, and so on. When it comes to transplant hospitals, and I'll wrap up here after this slide and hopefully provide, we'll have some time for discussion. But transplant hospitals do really benefit quite a bit from living donor transplants and being able to have robust living donor transplant programs. Part of that, quite simply, is the high proportion of commercial payment for living donor transplant, which are all reimbursed through negotiated case rates. But living donor transplants in general do, even in government pay patients, do allow for savings because those DRG reimbursements are typically fixed with some outlier mechanisms. But living donor transplants tend to do better in the hospital. A lot of hospitals are reporting lengths of stay of around 2 days or less, or 2 to 3 days, which is a really short length of stay, considering what it is compared to deceased donor transplant. And also there is a substantial recoup of organ acquisition costs through the Medicare cost report for living donor transplants, including all donor workup according to your Medicare fraction, as well as your HLA lab, paired exchange services, and so on. And so shifting even 10% of your total kidney transplant volume towards living donor will yield a significant financial benefit to a kidney transplant program. And so investment in issues to expand living donor transplant really can have a benefit for when you talk about the system, really your local system, meaning your transplant hospital. So in general, I think what this sort of adds up to is that living donor financial neutrality and making sure that there aren't really substantial living donor costs, which are a real barrier to donors coming forward and going through the process, can have benefits for, of course, how the donor feels going through it, how the donor feels after it, what can happen with the recipient in getting an earlier transplant, returning to work earlier, but also substantial savings to the system, especially in a time where healthcare expenditures are expanding, and there's a lot of uncertainty in how we spend money on healthcare in the country. And so any efforts that we have through the ASN or any other organizations, our patient advocacy organizations, to advocate and address financial neutrality more robustly for living donors will have a massive benefit, I feel, for potentially more living donor volume in terms of a number of transplants, but on the recipients and the system at large. And with that, I'm happy to answer any questions, and thank you for your attention. I apologize for being a couple minutes over.
Thanks so much for that really comprehensive talk. Appreciate it. I don't know how you put it all in, kind of hit every single aspect of the way that donors help the system.